the data that is updated is a little bit maybe not the best measure of what things actually look like because of the pandemic and how things went, right? So I think any data you have to keep in mind that's from sort of 2019 to 2021 is going to really maybe not fit in with the rest of your picture. But I think that when we talk about gender in medicine, and we really want to talk a little bit about what does it look like? We know our medical schools are kind of 50-50 male, female, but what does it look like beyond that? How are we doing in orthopedics? And I think, I can tell you about my experience, right? But how valuable is that? I really like to keep it focused on what the literature shows and what the stats show, because I think that we're all scientists. And so we really should be looking at what is science telling us about these things. And I was first asked to do a lecture on musculoskeletal oncology. It was called gender financial data differences. And I was like, I don't even know what you want me to talk about. But one of the guys in the Tumor Society asked me to talk about that. And then I started to sort of dig a little bit deeper. And I was like, oh, okay, well, here's what we're going to talk about. And so this is really an outcropping of that. I like to show this first slide because it can be a little bit inflammatory, but they love it at my home institution when I show this slide. And this is not a session about male bashing, right? Because I have been trained in a career that is almost exclusively male. And I've been trained by a lot of men that have been influential in my career choices, have been helpful as I've grown, have really shown me a field that I love. But I do think that pictures like this should allow us to sort of just open our eyes a little bit to say, like, there's, a whole nother 50% of the population that aren't even represented here. And we don't want to miss out on their talent, right? So that's really what it's about. If we look at our medical schools and they're half women, right? And then we do our rank list and we only put the men, then we're really getting, okay, I know that we shouldn't be talking about like the bottom of the class, med school class, but if you're only going, you have your 100 people lined up and you're not even selecting from the women, then you're getting the bottom of the men when you select, right? Does that make sense? So it's about getting the best talent in orthopedics. It's about doing the right thing in orthopedics. And I do think that our workforce is just better, right? I have a little bit of data surrounding that too, but I do think that our workforce is just better when we sort of work together and we learn about each other's differences. I think that makes us better doctors as a whole. So I'll walk you really briefly through medical school, residency, fellowship training, and really beyond, and try to keep it as unbiased as possible. So like I said before, med school matriculation, the data shows that we're pretty much equal. Most medical schools are 50-50. There are actually more female applicants at some medical schools currently. So we're looking at, pretty equal representation. What does the process look like when you apply to med school? Well, if you look at the data, men have higher MCAT scores and higher science GPAs. Women have higher total GPA and higher non-science scores. Once you get into medical school, well, what does that look like? Well, some of the work that has been done show that men slightly outperform women on step 1, and women slightly outperform men on USMLE step 2 CK content. Some studies show that women outperform men on clinical clerkship evaluation. So kind of pretty balanced as to what the performance looks like in med school. Yeah, is that really right? Does that matter? So that's the question of statistically significant or really clinically significant, right? Yeah, who knows, right? When you move on to residency, what do we see? Well, we see what we all know we see, which is that women aren't applying to the surgical subspecialties in the surgical fields. And if we look at where they are applying, we see that they're going into pediatrics and OBGYN in overwhelming rates, but not applying to the surgical subspecialties, right? Almost every, all surgical subspecialties are underrepresented by women. So they're just not applying. And that makes it challenging, you know, as program directors, when you're trying to really recruit women into your program. You want to be more diverse, but the women are not even applying. So I think this is, it's super important to have the med students. We have, you know, 5 med students here. How many med students? 5 med students, and we have 2 women. So this is your opportunity to engage with people that want to be part of the workforce. But I think sometimes we're just, we don't maybe necessarily feel inviting. I'm not sure why that is, but the report on residency shows that, again, we have, of the med school graduates, we have pretty equal numbers. But we know that women don't make the choice to do orthopedics, right? So our application to residency is about 15% of the applicant pool are female. Maybe it creeps up a little bit into the 16%. And we know what things make people more likely to do orthopedics, right? So if you have required musculoskeletal education in your program, that can be helpful. If you work to eliminate some of the negative perceptions that women have of the field, that can be helpful. Well, how do you do that? I think you have to start by also recruiting women to your faculty, right? So if you Google, you know, orthopedic surgeon, if you Google orthopedic surgery chair, you get a picture of this, right? That's not to say anything terrible about all the wonderful chairs that we have, but it can feel not very inviting when you're a woman and you don't see anybody that looks like you, especially in leadership. Some of the things that do also help influence the choice of orthopedics, I think one of the big ones is athletics, right? So passage of Title IX in 1972 allowed female participation in sports to increase. It started at 3.7%, and increased to 40% by 2014. So, and if you look at Ruth Jackson Society members, and they cite really the context in which they first came into to notice even orthopedics as a field, many of that was through athletic participation. And those athletes, many of them, some of them participated as professionals, some of them participated just in high school, some played through high school, many of them were college varsity level athletes. So athletics can really be a window or a door to allow women into orthopedics. My first exposure was with a stress fracture in the 80s. So I think that's notable here. So is it changing the number of females that are applying to the orthopedic residency programs? It is. It's slowly increasing. So, you know, 15 years ago, there were 11%, and more recently, we're at like 16, 17%. A few years back, we were at 14. So it is growing. It's growing slowly, but it's growing more slowly than any of the other subspecialties. So if you look at this data, you can see where orthopedic surgery is in our percentage increase. And we're just not really making huge gains, considering that we've had a predominance of women in medical school for many, many years, or since it's been equal for many, many years. We haven't been making the changes that we need to. I think the Academy is really looking at trying to improve upon this. And we can talk a little bit more about what the reasons are behind it. I don't think anybody knows, and I wanted this to be really more data and stats. I don't think we really actually know why women don't want to do orthopedics. We can make a lot of assumptions, but let's see what that looks like really in residency training programs. So one of the things we do see is that if you have a program that has a lot of females in it, you're going to attract more females. So it's hard to sort of get over that hump, right? You start with, our program is 30, right? We start with, at one point in time, we have 1 female. That was 2 years ago. And so it's hard for to recruit other women. So the programs that do manage to recruit other women then start to get more women. And then it seems like they get all the women. And you're like, well, all these women that we ranked, they went to NYU, they went to HSS. I think that can be challenging, but I think that's not the area that is most concerning. The most concerning, I think, is the programs that don't train any women and don't want to train any women, right? So that fortunately is improving, but you know, this study looked at programs, and there were some programs that had no female trainees for they looked at 5 years of not 5 years of residency, but 5 years of work and at all the classes, and they had no female residents in any of those 5 years. So that's improved, but still some work to go there. And then we can look a little bit at performance in residency, right? So what does performance look like in residency in terms of OIT scores and board scores? There's no difference in OIT scores that's significant. Board scores are slightly lower for women, but not statistically so. One of the things that is a little bit concerning is that females can require more in this study required more attempts to pass part one of the boards. So I think that's worth considering and looking at and making sure that if you are training female orthopedists, that you understand that, you know, OIT scores are correlated with board scores. And so if you see that OIT scores are lower early on, you need to have interventions. You need to make sure that they're doing enough of the ortho bullets, you're doing enough of the res study programs, whatever question studies booklets you can be doing so that you can make sure that your residents are passing the boards. What does it look like subspecialty when you go into fellowships? For some reason, hand is not on here, but many women go into hand, but we also see predominance of women in pediatrics, foot and ankle and shoulder. Spine is severely underrepresented. And sorry, say it again. I know, right? We're like missing things. So yeah. So, right, we get lumped in with the tumors, with the hip and joints. It's the same, like with the match, we use the same match that right. So once you've finished your training in orthopedic surgery, then what does that look like really too? We've seen a lot of studies. There was actually a new recent study that came out about complications after joint arthroplasties based on gender, right? So there was no difference. That was it really pretty interesting. There are studies that show that there is a difference though. So women spend more time with the patients and they actually wait longer before they interrupt. So average waiting time before interrupting by a female patient was 2 minutes. Guys waited 47 seconds. There are some studies looking at Medicare patients and readmission rates, right? Because we're quantifying readmission rates. There are studies that show that female physicians, patients are less likely to die or be readmitted over a 30-day period. So spending more time with patients, in which this will come when we talk a little bit more about income, spending more time with patients and spending, maybe having less complications or readmissions and lower death rates. These are not dramatic, but if you talk about like the whole country and we talk about, you know, how many women are in medicine, it can make a difference. And I think it's not to say, hey, we want to hire the woman because she's going to get better, but let's look at what she's doing that might help us take care of our patients better. And again, that goes to having a diverse work field where you really learn from other people's expertise. When you look at academics and women in medicine, you can see that there are fewer women really in the faculty at the assistant, associate, and full professor level. Why is that? Sometimes people talk about the pipeline and that women haven't gone through long enough to been in the pipeline to progress to full professor. I think that could be part of it. But again, we've had a lot of women in medicine for a long time. And so you kind of have to look at why perhaps people aren't getting promoted and what's happening beyond that. So if you look at some of the data on that, we can look at H-index scores, right? And you can look to see whether or not the H-index, which is a measure of academic productivity and thus promotion, right, would be different between male and female. And we find that, and they've done similar studies in ENT, but we find that there's really no significant difference except really at the assistant professor level. So what we see in the data is that women take a little bit longer to sort of get started in their publication progress, essentially, and then they start to catch up a little bit later. So that could be, and again, I don't have data on this, but that could be because you spend your whole residency putting off childbearing and then you're finally done and then you decide to have children and now you're coming back to the workforce and you're sort of a little bit behind in the publication arena. It could also be that there are less opportunities for mentoring or for studying. You know, we don't really know. It could be because we don't have leadership that, again, looks like us. So this looks at really where we're making progress and where we aren't making progress. So We haven't changed really. Med school deans were still about the same. And again, this data hasn't been updated through the pandemic. Department chairs, and this is all across the board. This isn't just necessarily orthopedics, but this is, this is what we're looking like. And I think there are very few female chairs across the country. So maybe women aren't getting the support they need to work on publishing or being promoted, or having those positions that lead to promotion, right? Or maybe they're having positions that don't lead to promotion. So I'll talk about that in a few minutes too. Again, if you look at orthopedics compared to the other subspecialty, I mean, this is where we are, right? So compared to ENT, compared to ophtho, compared to general surgery, we're all doing not well, but I think it's been stated over and over again that orthopedics is really at the bottom of this in terms of how well we're doing. And again, if we only have 15% of the med school of the applicants to our whole pool in residency as women, you're just not going to have the pool to choose from to allow them to get to the professor, associate professor, assistant professor, and chair level. What I talked about before is maybe they're doing something different that doesn't allow them to progress. So many chairs start as program directors, so that can be somewhat helpful. But sometimes it can be a detriment to your career as well, because you're spending so much time working on resident education that you're not publishing, you're not networking, you're not navigating the ladder that you would need to climb if you're going to get to a chair level. So we do see that this study is a little bit older, so it's not accurate now because we do have women chairs. But at the time, there were no department chairs in orthopedics, but they had 11% of their program directors were female in academics. So this study was actually sort of looked at to see if we think that women are being asked to take on leadership roles that maybe don't help them progress, right? So if you're on I'm going to try to think of a hospital committee without being mean, that is like really not useful progressing in your career, right? But we can all think of those, right? There was a value analysis committee, right, where we had to decide if the lens that the ophtho guy wanted to bring into the hospital was worth the value. Well, I don't really have any expertise to say whether or not that's true or not. If he says he needs it, I'm going to have to go with that. But spending time on some of these committees, you might be really good at it, you might be really organized, but it might be also taking away from other avenues that you could travel that you might also be really good at, and that might also get you to a professor or chair level. So I think we have to look at that when we're assigning tasks, that we want to make sure that we're not assigning all of the menial tasks. And sometimes it can be as blatant as like, can you get the breakfast, right? Well, why am I getting the breakfast? Or can you make sure that the call room's cleaned up? Or why am I cleaning up the call room? So I don't think that's really happening anymore, but I think that you have to look really at a granular level at what that really looks like when you're being asked to do additional service work for your department. And is that being sort of doled out fairly? Finally, really, I wanted to talk a little bit about what compensation looks like, right? Because there's a lot of data but there's still a lot of questions about that data, right? We hear like, oh, women make 80 cents on the dollar. Well, why is that? What does that look like? Is that really true? So what does the data show about that? And I'll talk a little bit about some of the studies that were done and then one of the studies that we did. This study where they looked at medical and surgical subspecialties, they found that the male gender was associated with significant increase in salary, even after adjusting for specialty, rank, leadership, publication, research time. So they are able in most studies to show that there is a difference. The question is that first of all, is it a real difference? Second of all, is it explainable by some other factor that isn't rank, specialty, publication, and research time? If you look specifically in orthopedics, you can see that published data does show that there's differences in salary. But we wanted to know really a little bit more about whether or not it's based on RVU or volume or negotiation related. And so we wanted to look a little bit more at other variables on surgeon income. So here was our hypothesis, right? Like Was it based on gender, work hours, number of procedures? Do we have this data? And what we did was we utilized the AOS census data. So every year the AOS sends out a survey to orthopedic surgeons. And it's voluntary, you send it back. They have all sorts of data that they collect. And then they publish a little thing, like a summary of it all. Not a little thing, it's pretty intense, the summary. And I was like, well, they have all this data, like, will they let us look at the database? So they won't give you the data, but we at the time could query the database. So we sent them some questions and, had some great, wonderful medical students that were fantastic with all the questioning and the statistics and the running the stats, but we sent them all the questions. They actually gave us, a lot of valuable data. But our hypothesis was that there are differences in compensation that can be explained by some of the variables. That's what we really thought. I'll let you read this guy. This is what somebody else thinks about the pay gap, which could also be true, but that was essentially our null hypothesis. Right, so there might be some truth to this, but you probably shouldn't put this on Twitter because then you're just going to get totally trolled. There may be some of this, and we don't actually have a good way to quantify this. There are some times that you choose, hey, I want to take less call, which means less income because I want to be home, right? So I think there are some societal differences, and that's okay, right? But I think that when we say women are making 80 cents on the dollar, we have to make sure we understand that some of those factors are influencing, are or are not influencing what happens. So again, we looked at the AOS data. We generated 19 questions. Oh, sorry, the survey is 19 questions, and we looked at all those. And what I thought was interesting was that they do this every few years. And in 2008, they had income reported along gender lines, but then in 2014, they started to not report it. So I was like, well, I don't know why they didn't do that, but we were able to get to work with them to allow them to give us some data. And overall, we found that there was a significant difference in incomes between male and female within the 6,805 respondents. And when we looked at sub-analysis and we looked at full-time, which means working more than 40 hours. So, right, is one person working 60 and one working 80 and one working 40? We don't know necessarily, as well as among surgeons with the similar amount of experience in practice, right? So your younger surgeons are going to probably be making less than your older surgeons. And we also were able to look at surgeons who perform more than 26 procedures a month. And what was interesting is that if you did more than 26 procedures a month, so you can see that line here, that was not statistically significant. So there's probably an element of how much work you are actually doing, right? And why that happens, maybe you're spending more time with patients, so you're not seeing as many patients, you're doing less procedures. Maybe you're not getting the referrals because there might be a referral bias. We do have studies that show that when a woman makes a mistake, she's less likely to get another referral from that doctor than if a man makes a similar mistake. So are there referral biases? But we do know that if you're doing the same number of procedures, you're generally making a similar amount of money that isn't statistically significantly different. Sure. Yeah. Right. Yeah, it might actually be the opposite, right? So you might be in private practice, and in private practice, your metrics are income, right? It's like, we want this many RVUs, you need to be doing this many cases. We're not maybe as concerned about your publication record, but there might be more support for the goal here is to be doing more surgeries to generate more income because you're in private practice. Whereas in academics, we might have some of those other competing interests, right? You might be assigned to be a program director, which takes a lot of time and decreases your income. You might be assigned to be on a committee. You might be focusing more on your publication record. So maybe not be that kind of support. So that could be part of it. Yeah. There probably is, and that's probably in the AOS census survey, but we didn't look at that in this study. But the survey is pretty interesting because it does give you all the information about people that responded to the survey and how many people are doing what, how long they've been in practice, how much people are working, how much vacation time they're taking. There's a lot of data. Yeah. I don't know the answer to that, but I think that it was just reported income. So they don't ask you those specific questions. By subspecialty, there were differences. There were percentage differences, but many of them were not statistically significant. Yeah. Yeah, hands in here, huh? So what we did then with the data is we did a regression analysis where we controlled for subspecialty, hours worked, work case, work status, like full-time, part-time, case volume, years in practice, practice setting. And we found that there was a statistically significant difference using the regression analysis overall. So I think that was the big take-home point. There was a difference. It maybe isn't as much as sort of that 80-20 or the 80 cents on the dollar. But there is a difference. You have to think of it over the course of a lifetime, right? So if you're talking about working 20 years in practice or 30 years, you're talking about, over $1 million, right? In difference in income. And again, I think the other thing that was significant was that we didn't find a difference if you did the same amount of cases. So they've done a lot of Medicare studies. They've done Medicare studies too. Looking at that, like sometimes they do a Medicare study to see if Medicare is paying the female surgeons less than they pay the male surgeons. I'm like, okay, well that doesn't happen. So we know that there's not disparity there. Like we're all getting essentially paid the same amount for doing the same number of cases. So really, what are some of the things that we weren't able to study that might lead to some of the differences in income? Well, there could be work-life balance differences and people, choosing or prioritizing that. I think negotiation differences are a huge thing. Procedure volume we talked about. And then I think the thing that we worry about is there a bias, right? Is there a bias? Is that why women are making less money? So let's talk a little bit about work-life balance. I think that's important because you look at it and I joke, I shouldn't say this, but I tell my partners, like, one of the things you have that I don't have is a wife, right? At home, oftentimes helping make things run, right? I do have wonderful, help support at home. My husband's great. So but I think that when you look at it, you see that that women are more likely than men to be partnered to another professional. 74% of women were partnered with full-time professionals versus 18% of men, and 84% of women partnered to another physician. Like that's just got to be really challenging versus 23% of men. Women are more likely to help with a lot of the household activities, childcare, meal planning, grocery shopping, vacation, all that kind of stuff. So that could be one reason why there's a difference in income, right? Because you're working outside of the home and you can't work as much at work. Negotiation strategy, I think, is a big one. This Professor Linda Babcock, if you're gonna get a job, read her book. I mean, I don't think you have to be a woman to read her book, but there's a lot of really good literature that she's published. She's from Carnegie Mellon, works as a professor of economics, that shows that women just don't even ask for more money. So they looked at MBA grads at Carnegie Mellon, and the males had a higher starting salary of 7.6% than the females. And this was simply because 57% of the males asked for more money and only 7% of the females asked for more money. So there's this sort of nice girls don't ask kind of mentality. And there's also the concept that men will women will wait until they sort of achieve a ranking before they ask for that support of that ranking. But men will say, oh, I'm going to get there, so let me ask for the support before. So I think there's a lot of great books that you can read before you negotiate. Sheryl Sandberg has Lean In book. These are two great books. And I think that they do help. They really sort of set the stage for how do you do that? It's not just asking for it, but it's also talking to your friends and finding out how much they're making, finding out what a position might be worth, thinking about what else you might want besides money. Do you want another week of vacation? Do you want more flexibility? Do you want a car? Like, what is it that you also want, when you're looking at that? And potentially women are getting those things instead of dollars, right? They might be getting, again, less call or a more flexible work schedule. I'm not going to talk too much about procedure volume because I think a lot of the procedure volume, when they look at overall data, we're looking at women and men in all of medicine, and more men are in procedural related specialties. So that's where a lot of that income data comes from. But it does bring up sort of, again, if you talk about women having lower procedural volume, Are they spending more time with their patients? Is there a referral bias? Are they doing more administrative tasks? Are they choosing to work less? And then, really, what can we do to make this better, right? So we have to really look and see, are we assigning more women to underpaid or unpaid work? Are we promoting at equal rates considering publications? Are we compensating equitably? Are we giving equal pay for equal work? That's what we really need to be focused on. And some of the ways we can help with that is by training to avoid unconscious bias. See, my residents see this and they take a picture and they send it to me, which I think is great. I'm like, yeah, like this was in our medical school, right? In our medical school. So, right. Thank you. They got like that. I got to add that. That's right. We wouldn't need caution. That is actually great. Thank you. So I think that some of these unconscious bias training help, but actually the data on unconscious bias training shows that the more modules and more lectures we go to, actually the worse it is. So when I made this slide, this is what we were doing, but now as some of the literature is coming out, there's a little bit of a backlash with all of that. Like nobody wants to be told that they're doing crappy, right? Nobody wants to hear that. But I think maybe hopefully having just a lecture like this to just stimulate the thought of, hey, we want our programs to look different because that makes us all better. It really does make us all better. So really, where do we go from here? Well, we continue to work on some of the AOS data and move towards publication. We need to make sure our conversations are data driven, right? Because just like I said about the unconscious bias training, some of the data now coming out is saying that all the stuff that we've been doing is not actually helpful. That what we really should be looking at is, if we want to have a more diverse work group, is figuring out how to get the females interested in orthopedics first, right? So we need to go back a couple steps rather than having unconscious bias training. So I think we need to have data-driven conversations. What works? Why is it happening? Why do we want it? And have that be focused on our data, because we're scientists, right? Increase awareness and, again, looking for the reasons, and then really working collaboratively to reduce any potential inequalities. So if we do have a diverse work field, we want to make sure that our diverse work field is treated fairly. And this is our picture. Actually, we didn't have enough female orthopods at the time to take this picture, so we had to have our ENT colleague come in with us. So I hope that's been helpful for you guys to hear just a little bit about what the workforce looks like, what some of the challenges are. I've been fortunate to train and work in a career that I absolutely love for 22 years. And I think really for me, it's about wanting other people to see that it can be a great career, right? And you can still have, and we can talk it could be a whole nother lecture on how you have a child in residency and in fellowship, and then the one as an attending. So, setting the stage for, there can be people that look like you, and getting those people and coming into orthopedics can be very gratifying, and having people that don't look like you can help you as a surgeon and as a practitioner. Go ahead. Sure. Right. Mm-hmm. Right. Right. Mm-hmm. Yeah. Yeah. Right. 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 Yeah. 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 Right. Yeah. Yeah. Yep. Yep. Yeah, so I think a couple different things there. You know, one is you're right. Like you can't catch salmon if if you're fishing in a sea with only trout, right? So if the women aren't applying, it's going to be challenging. I do think that keeping your own at your own medical school, that's super helpful. Most of the women that are in our program from our own program. So starting early on, work on them with research, have them come to clinic, be inviting, recruit them for your own program. I think that can be super helpful. With regards to sort of having children in residency, the ABOS requires, they may have changed the rules since I'm not program director anymore, but they require that you do 46 weeks of training in a 52-week year, right? So it used to be you could essentially get 6 weeks off a year. So you get your 4 weeks vacation. Then if you had a baby, you could have like 2 more weeks, right? Now they're allowing you to combine those years so that if you needed to take a maternity leave, you're not going to be able to not sit for the boards. So you can use your 2 years from other years. Lab rotations can help if you have lab rotations. It makes it challenging for people that are staying behind too, right? We've done studies looking at burnout when we have reduced resident complement. That hasn't been for maternity leaves, but that's been for, you know, if you've had a position vacant or somebody left the program and then you're down resident complement, you know, that's stressful for everybody left behind. It's more call, it's more hours. And I think that, you know, program directors have to be mindful of that. I think there's a really, you know, the culture and then the culture, right? So the culture is, this is what residency looks like. And yes, you have to do 5 years of orthopedic training, but does that have to be 5 consecutive years? Is it normal? Is the culture that the residents that are left behind to do the work and no, the program is not under any obligation to help, you know, subsidize that with mid-levels? Right, that's the culture that we're in. I think that changing that culture is super important if we're going to sort of make this work and make accommodations. And I also think that as more millennials sort of come into this and sort of become more aware, I do feel like they're more aware that there are gender roles and they help out a little bit more at home. So some of that helps too. But also seeing men take paternity leave and sort of normalizing what that all looks like is also helpful. So there are ways to make it better, but you're right, there's a lot of challenges. Yeah. Go ahead. Yeah. Yeah. Mm. Right. Yeah. Right. Yeah, yeah, no, I will say that, to be honest, when we do get female candidates, they're really good. You know, some of the ones that are applying have maybe gone above and beyond what anyone else has done. But you're right, you can't select based on gender, right, for your job, right? So it is a factor in what, you know, you're trying to recruit and have a more diverse field, but that can't be the reason that you're putting them on the rank list. I will tell you, when I applied for residency, I was at Columbia and we had probably 10 or 12 people applying. And Jefferson interviewed 2 people from our program. It was both of the women. So, you know, I can see the frustration with that. I think that the programs, you know, many of the programs, like we interview 75 people and we probably go down to, you know, 20 on the rank list. So there's a lot of room for, you know, interviewing a lot of candidates. But you know, we struggle the same as everybody else. Again, if you only have 16% of the women are applying, you're only going to get at best that, right? I don't know if you want to chime in on that, Dr. Gatt. Yeah. Right. Yeah. Yeah. Okay. Right. 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 Yeah. Mhm. Right. Right. Yeah. Yep. Yeah. No, certainly those kinds of things. I decided I was going to work in Jersey. My husband's in the city, right? We couldn't really foresee we were in Jersey, like two people being in the city while your kids are in Jersey all day long, right? And didn't really want to make that move. So, those things you definitely make those choices. And I chose to be in academics, which, your income potential can be decreased in academics because I've I felt like I needed the residents to be able to sort of get me through the night, right? Like so that was one of the reasons that I stayed there. And I think also to your point about the AOS, there's a Women in Orthopedics Facebook group, which is really nice because it's not all AOS, it's not all academics, right? So you get to be involved in conversations where people are talking about their practice and they're talking about contracts and they're talking about RVUs or insurance negotiations. So you get to really see some of that that's probably missing from the academy. I think the AOA does a little bit more of sort of not clinical work, but again, it's still very academic. Yeah. 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 Right. Yeah. When we get there. Yeah, well, I would say like why, you're right. It probably isn't going to get to 50-50, but why not? Right? Why is OBGYN more women and less men? Why pediatrics? Like what is it that people don't, why do people think that it can't be that way? Right. So I think it's just generally a stereotype, right? That women don't want to do this, or they don't think they can do this, or, that the work-life balance wouldn't allow for it, but why does the work have to look that way? So I think that that's one of the things that, I didn't feel that way when I was sort of first starting out in the orthopedics, but as I get a little further along, and maybe I read too much on Instagram and Facebook and all that stuff, but as I get a little further along, I do think that we have in our minds, this is what orthopedics looks like. This is what residency looks like. This is what practice has to look like. And like your wife, she could decide to do plastic surgery and maybe back out a little bit. Why can't you do that with orthopedics? And would more women want to come if you could back out a little bit? Do you have to work 80 hours a week? Do you have to earn over $1 million? Do you have to devote your be all end all to that? Would your patients be better served if you had a better work-life balance and you were more rested and you had a lower caseload? I don't know the answers to all those questions, but I would say I would challenge that and just say like maybe it could be 50-50, and why couldn't it be? Yeah. Thank you. Yeah. Mhm. Yeah. 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 Mhm. Right.
I wasn't looking at, the faculty, and no one was Indian. I wasn't looking at their sex or that kind of stuff. So it'd be interesting to see if there's an objective like survey you can have and see what were the most salient factors for people in orthopedics for actually choosing it. I think that could be helpful in answering kind of Jeremy's question. It's like, what is the number that we will know that we're doing like good on this kind of this front?
Yeah, I don't know if there's studies that look at why people choose it as a field. I think as a program director, and Dr. Gatt can probably chime in here, many of the essays that we read are sports related injuries, right? So that's one of the big ones. There's also a lot of people, not necessarily guys, but mostly guys that like to work on their cars. There are also a lot of guys that like to build things, right? They do a kitchen repair, they work with their grandfather, and those things are valuable. But I do think that those, again, some of those things are cultural, like what, I can't even speak for myself because I would never change a tire. I have called AAA, but girls aren't out there fixing their cars. So then they're maybe not, getting exposed to what that looks like and then feeling like they can feel comfortable in an OR in a mechanical setting. But why can only a guy learn how to change a tire? I don't know. If anybody knows how to change a tire, I can take a lesson. But I think, that it starts early, right? It's not just medical school. And we can't just fix this in medical school. But I think, feeling comfortable with a screwdriver. Like I teach my daughter, this is a Phillips head, this is a flathead. Like she's 8, you know what I mean? But I feel like just even early on, making sure that the girls can see that this is a possibility. You can also, do carpentry work, right? You can also change a tire. I'm sure there are better examples, mow the lawn, whatever it is, right? That sort of is your stereotypical what an orthopod looks like. But even if you can't change a tire, you can still do orthopedics. So that's, right. Exactly. Right. Yeah. 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 My daughter's doing a Python class this summer. So you're going to go get some computer science at 12, right? I don't know if you're going to do anything but like, I don't know, move blocks around, but I don't even really know what that means. But I think you're right. Like trying to introduce women to different fields early on. Yes. Yeah. Yes. Yeah. 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 No, I advise the same thing. Yes. Right. 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 The answer. Right. Yeah.
I think the reciprocal way to think about it is like, say for the current situation, only 70% are matriculating to ortho. There must be another percentage of females who have gone to other specialties who are now unsatisfied. If we think that number should be higher. So is there any like data out there, or even this anecdote from your classmates, people who are not satisfied with their specialty and wish they could have been an ortho? Let's looking at satisfaction rates between the specialists and see what they would have been done.
Yeah, I haven't seen that, but I did meet an ENT doctor on Monday who was like, I really wanted to go into orthopedics. So, maybe there are people that are out there sort of. Right. I think so. Right. Yeah.
The last thing is, so I was at the AOA leadership forum like last week in Rhode Island.
Yeah.
And they were saying that, looking at like stats and people applied to people who matriculated, I think men and women, there's not like a difference or a bias, but amongst race there is still. Do you have any thought? I'm not sure if that's true or not, but from what you've seen and what you've experienced, do you agree with that statement or disagree?
Yeah, I don't have the knowledge to really comment too much on that. We wanted, when we did the study on income in orthopedics, we wanted to go back to the academy and look at the database and look at it in terms of race. But by the time we got done with the study, I think the academy was kind of done dealing with us. So we weren't able to do that. I'm trying to think of some of the studies that are out there on that. And I just don't know them off the top of my head, but they have looked at matriculating ortho residency and race, and they've looked at OIT scores. So some of that data is out there that you can look at. Yeah. And that's going to be different because now we don't have step scores, right? So that's going to look different as we get down the pike and what other scores we're going to be looking at. But I think one of the key points here too is that we want our applicants to also be successful. So while, while there is sort of a desire to, have a more diverse work field, we also have to make sure that the people that are coming are able to pass the boards, right? So we have not done anybody a service if they aren't able to pass the boards. And so that's why we're so conscious about step scores, because step scores are correlated to OIT scores and OIT scores are correlated with board pass rate. So I think that, as much as we want to train and recruit a diverse workforce, we also have to make sure that we are conscious of what the bar looks like and why the bar is there. Go ahead.